طيب السلام عليكم everyone. أول شيء جد thank you for everyone for coming. يعني بعرف الدنيا رمضان وهيك تعب، وصدقا I've been waiting for this day for so long. يعني بس كنت أدرس الهارد شابتر كنت دائما بتخيل حالي إني عم بشرحه، so I'm so glad الحمد لله إنه إجا هذا اليوم. قبل ما تعرفوا علي وعلى my colleagues وقبل ما نبلش شرح، وصلني كتير كلام وبعرف إنه يعني أول 2 quizzes لبايو وكم they were not the best، وعم تحكوا إنه الأسئلة إنه شوي it's not direct، الأسئلة صعبة، فحكيت إنه يعني شوي هيك heart to heart talk، كلام طالع من القلب، وأتمنى زي ما هو طالع من القلب إنه يوصل لقلوبكم كمان وتضلوا متذكرين حتى بس تطلع من هدول البابين. في حديث كتير بحبه حابة أذكركم فيه، ويعني اطبعوه خليه دائما قدامكم. قال الرسول صلى الله عليه وسلم: من سلك طريقا يلتمس فيه علما سهل الله له طريقا إلى الجنة. I'm sure كل حدا بهاي الروم ندرس بالساعات وبنسهر، بس لو جد انتم صادقين النية، يعني كل مرة بتقعدوا بتدرسوا تكونوا مخلصين النية انه يا رب انا كل معلومة عم بتعلمها حفيد عبد من عبادك. تخيلوا قد ايه انتم عم تاخذوا حسنات، وقد ايه انتم عم تتقربوا من ربنا اكثر واكثر. هاي شغلة. الشغلة الثانية، ربنا ما بضيع تعبكم، يعني مش استهزاء او انه عم بقلل من تعبكم، بس I'm sorry to say this، أنا مو هون عشان أعطيكم motivation صراحة، أنا I'm not a motivational speaker، بس as long as إن results ما عم بتكون زي ما أنتم بدكم ف there is something wrong. مش يعني أنتم ما عم تدرسوا كفاية، بس طول ما أنا عم بحكي إني أنا عم بعمل اللي علي بس results مش زي ما بدي ففي إشي غلط. فالله again ما بضيع تعب حدا، وأن ليس الإنسان إلا ما سعى وأن سعيه سوف يرى، بس at the same time الله بحب لما عبده يعمل الإشي يعمله بإتقان. فماي ادفايس فور يو، يعني هي هيك اعتبروها من اختكم، انه تقعدوا مع حالكم شوي تصالحوا حالكم. يعني for example if you're repeating one subject او let's say تنتين، افتحوا جيبوا quiz 1، علامات quiz 1 quiz 2 did I improve؟ نفس العلامة ولا العلامة قلت؟ فاهمين علي؟ مثلا اذا you're not repeating عم تاخذوا كم 2 باي 2 بس العلامات ما عم تكون تمام، هل انا عم بغلط باناتومي؟ هل انا عم بغلط بالفسيولوجي؟ لازم تصالحوا حالكم انا where's my weak point، لانه طول ما انا بحكي اني انا عم بعمل علي صدقوني ما حنمشي خطوتين لقدام. and I used to say this sentence لماي friend هون، انا عم بعمل اللي علي، بس الله كان دائما يثبت لي انه no this is not your limit، يعني الله عارف انه انتم عندكم potential اكثر و your limit is triple. تمام؟ وذاتس ات. يعني again بس حاولوا تعرفوا شو المشكلة، and also it's fine to ask for help سواء ل your friends ولا your colleagues. احنا PACademia، وبالنهاية اللي ربنا كاتبه رح يصير، واختيارات ربنا دائما أحسن. and now we can get started. عندكم أي شيء حابين تحكوه؟ اوكي طيب so ما I don't think أنا I know you ولا you know me. أنا جود عبدين إن شاء الله today I'll be explaining the anatomy part and my colleagues will be going through the physiology part. فنبلش بالبasic very basic info، يعني كل حدا عارفها. إحنا عندنا الهارت it is the size of the fist which extends from the second rib للsixth rib. تمام؟ أنتوا لما تحطوا your 2 fingers بين الfifth والsixth rib you will be able to feel apical impulse. شو apical impulse؟ هلا إحنا عندنا الهارت it is cone shape. تمام؟ هاي البرود area الفلات area this is the base and it is toward the right shoulder. and هاي اللي هيك هاي هي الابيكس it is toward the left hip. فلما احنا الهارت is contracting هاي الابيكس it will be touching الثوراسيك wall، فحيصير عندنا هاي الابيكال impulse. اوكي كمان it is covered in the mediastinum اللي هي هاي اليلو which is in the thoracic it's a cavity. و just general orientation انه the heart is anterior to the vertebral column, it's superior, it is posterior to the sternum and it is superior to the diaphragm. اوكي هلا نبلش الجد. So anatomy I know it's all about memorization، بس صدقوني إذا فهمتوها وصلتوا لمرحلة إنه تتخيلوا شو أنتوا عم تدرسوا it will be very easy. فforget هون ما حنطلع على السلايدز ولا على الكلام. We have the pericardium. تمام؟ البericardium it's a double sacked membrane. أوكي؟ رح يعطينا الفايبرس pericardium ورح يعطينا السيرس pericardium. حلوين؟ الفايبرس pericardium it is made up of dense connective tissue. يعني من اسمه dense connective tissue so it's important for what? Protection. It will anchor the heart to the surrounding structures. It will prevent the overfilling of the heart with the blood. تمام? So we finish the first layer or the first membrane. Then we have the serous pericardium which is the visceral layer and the parietal layer. دائما وابدا لما انا احكي visceral يعني الvisceral it's the part that it's touching the organ itself. وparietal تذكر انه احنا عندنا P فهي الابعد، اللاير الابعد عن الاورجن. اوكي؟ هلا I know I said انه we have الvisceral parietal layer، بس one thing to mention they're not separated layers. يعني don't judge my drawing. بس yes. Oh sorry. So fake heart we have the heart one and this is the, guys, can you see? Okay. This is the thoracic wall. بعدين we said we have the fibrous pericardium. هي the outermost layer. Okay, so it's right here. Hi, fibrous pericardium. Okay. Then قلنا شو عندنا تحت الفايبرس pericardium على طول؟ Which one? Parietal ولا visceral? Parietal لأنه هي الأبعد. So هنا عندنا parietal layer. Okay, parietal. Here's the trick. parietal layer نفسها it will bend inferiorly لتحت هيك and it will enclose the heart. فهون صار عندنا شو؟ visceral layer. ممتاز. ف they're not separated layer يعني هي نفس layer it bends, it goes inferiorly and it encloses the heart. تمام؟ Then هون عندنا this space اللي هو شو؟ pericardial cavity. هلا in the pericardial cavity شو عندنا؟ serous fluid. لأنه this يعني imagine this is the visceral layer and this is the parietal layer. So when the heart is contracting لازم احنا يكون عندنا gliding motion. ف that's why we have the fluid. So you have to understand the normal function عشان هلا رح نحكي عن الابnormal. ف let's say إنه احنا عندنا أقل serous fluid. شو حيصير؟ friction لأنه هون layers they will stick together فحيصير عندنا friction. So the friction يعني pericarditis. And the key word here إنه the patient will come complaining from pain deep to the sternum. تمام؟ هلا if it was left untreated, okay, if it was left untreated, حيصير عندنا cardiac tamponade. كيف our body will try to compensate the fluid loss. So شو حيعمل؟ حيجيب fluid from the surrounding tissues. بس the problem here إنه it will bring excess fluid. ما حيجيب الكمية اللي احنا بس بحاجتها. So حيصير عندنا يعني like a larger space. فهون the heart has to put double the effort إنه يعمل its work. It can be treated very easily with a syringe يعني they can remove the excess fluid. Do you understand? Is it clear? Okay. Let's check. So who would like to answer? Any volunteers? Should I read the question? Okay. So we have a 55-year-old patient was admitted to the A&E in Al-Qasimi Hospital complaining of chest pain and shortness of breath. Physical examination and ultrasound of the heart showed a big amount of fluid around the heart. Which of the following is the most probable site of this fluid? Yes. Between parietal and visceral layers of the pericardium. صح. Can you give him a cookie? فيك انت تعطي. Thank you. انهم يجي ياخذوا؟ لا ولا انا اوكي. طيب the other question. Wait. Okay. طيب did you see the answer? إن شاء الله لا. Okay. Which of the following is true regarding the coverings of the heart? Yes. The fibrous pericardium. صح. طب why it's not B?
Connected layers, they're not separate.
برافو. I think هيك حناخذ وقت.
Thank you.
You're welcome. Guys خلاص اللي بيجاوب صح انتوا لحالكم يعني take after this session عشان not to waste time. Okay? طيب next. يلا سارة. Correct. طيب, take your cookie. Okay, so moving to the layers of the heart wall. هلا we have three layers. We have the epicardium, myocardium, and the endocardium. هلا the epicardium you have to know it's the same layer of the visceral serous pericardium. يعني هي نفس اللاير. اللهم إذا أنا بحكي إنه إذا it's about the covering بتكون visceral. إذا أنا I'm referring to the heart wall it is the epicardium. Here it's the outermost layer as you can see right here. It can be infiltrated with fat in elderly people. Then we have the myocardium which is the bulk of the heart. يعني it does all the function تقريبا لأنه it's the layer that contracts. It's the muscle. بعدين we have the endocardium which is the smooth glistening sheet, endothelial sheet. And high layer keep in mind إنه it's the layer that is in contact with the blood. المyocardium and epicardium they're not in touch with the blood. We will know about its circulation very soon. Question.
C?
Yes, correct. Okay, so هلا احنا حكينا عن الهارت as a whole. We have now to dive deeper. عندنا we have 4 chambers. So you know we have 2 atria and 2 ventricles. اللي هم الاتria, they're the superior chambers and they have thin walls. They're not part of the heart pump. We have the ventricles, يعني very basic information. They are the discharging chambers and they have thick walls and they are the actual pump. مين actual pump? اللي هو left ventricle. تمام? For now I want you to memorize something. إنه the right ventricle is attached to the pulmonary trunk. والleft ventricle to the aorta. يعني هاي you have to know it by heart لأنه when we talk about the blood flow والvalves وهيك لازم تكونوا عارفينها. So the right ventricle مع شو؟ pulmonary trunk والleft aorta. برافو. طيب. كمان هنا عندنا إنه ال right ventricle it has thinner walls as you can see. It's a crescent in shape and it wraps around the left ventricle. والleft ventricle it's rounded in shape and it has thicker wall. Okay. هلا we have 4 chambers. ال 4 chambers اعتبروهم كأنهم غرف. احنا بين الغرفة والثانية what do we have a wall. فالseptum it's like a barrier, it's a wall. لأنه شوفوا on the right side we have oxygen poor blood. Okay, and on the left side we have oxygen rich blood. فمش منطق إنه الدنيا تكون هيك سايبة بين البلد. So there should be a barrier. And from the name عندنا interventricular septum يعني it is between the ventricles. وseptum يعني barrier. And also we have the interatrial septum. تمام. هلا in the before birth we have هون an opening. هاي الاوبننج موجوده بالفيتس. ليش؟ لانه هون يعني it allows the blood to bypass the lungs لانه هون الفيتس بيكون عم بياخذ الاكسجين from the placenta. و after birth يعني it's called the foramen ovale and after birth it's called the fossa ovalis. It's important, memorize it. Okay. Guys, كل شيء واضح؟ أكيد؟ Yes.
Are they the name of the heart or are they specific?
لا, it's the name of the opening. يعني هاي الاوبننج هي الفورمن اوفالي. Once it gets closed بصير اسمها الفوسا اوفاليس. Okay. طيب. Who would like to answer? Marvelous. Yes, correct. Take your cookie. طيب. هلا moving to the anterior posterior view. When you look anteriorly شو أكتر شيء أنتم شايفينه؟ What's taking the bulk of the anterior view? Right ventricle. So the right ventricle it occupies the anterior view, and in the posterior view we have the left ventricle. Then we have the coronary sulcus. I think you took what sulcus in bio 1. هي shallow groove. Okay, so إحنا عنا التنتين. We have the coronary sulcus, which is this green line. It is between the atria and the ventricles. And we have the interventricular sulcus. من اسمها interventricular. So it is between the ventricles. تمام. Yes. Oh, sorry. طيب هلا let's dive deeper كمان. We have the right atrium, okay, and هون I'm talking about the right atrium internally, okay. شو هون في وراي؟ wait. هون حيطة صح؟ smooth. So always remember it. The posterior wall of the heart, right atrium, it is smooth wall. بعدين عندنا like ridges هدول اللي هم pactinate muscles. They're like the teeth of a comb. تمام؟ What else? Okay. Also كمان عندنا هدول small wrinkles يعني هون من برا. They're called the orcas and they increase the atrial volume. هلا هون we have 2 questions in how many openings we have in the right atrium and left atrium. بس يعني it's unfair to ask them now لأنه still I did not explain. But remind me to ask you again later. طيب. Moving to the ventricles. الفنتريكل غار كيف انه احنا عندنا ridges بالرايت atrium اللي هم الباكتينيت muscles. انا كمان عندي ridges اللي هم called the tubercles. Sorry. Right here. Okay. هدول ridges. تمام. And we have the papillary muscles and the chordae tendineum. These two are very important for the valve's function. Keep it in mind لأنه it will be explained just in a bit. طيب. So هلا الفالفز. What's the function of the valve? بالضبط. We have 2 types. عندنا ال AV valves وعندنا ال SL valves. ال atrioventricular valves and the semilunar valves. So ال atrioventricular valves from the name atrioventricular. So it is between the atria and the ventricles. On the right side عندنا شو? Tricuspid valve. And on the left side عندنا ال bicuspid or the mitral valve. Okay? Let's see how do they work. Who can read the steps? بس هيك read them. Yeah, you read it. Sorry?
This is in the books, huh?
Yeah, it's from your book.
It's hard to see.
You want me to zoom in? Yeah.
Blood being carried to the heart fills the atria, passing against the AV valves. The increased pressure forces AV valves open. As ventricles fill, AV valve flaps hang limply in the ventricles. Atria contract, forcing additional blood into the ventricles.
Okay, for me when I read it the first time ما فهمت إشي. أنتوا فاهمين؟ طيب أنا gonna explain it بدون الكتاب. I just want you to imagine إنه this is the valve. Okay, forget the book. إحنا هنا عنا this is the valve. Okay. فوق عنا what the atria. تحت عنا the ventricle. Okay. The valve it's like a one-way door. يعني it can only push. تمام؟ يعني ما you can't pull it. حلو؟ لا it's clear. طيب هلا in the atrium it gets filled up with blood. فشو رح يصير للpressure؟ It will increase. لما أنا يصير عندي increased pressure شو رح يصير للvalve؟ It will open صح؟ It will hang limply which is the second step right here. تمام؟ بعدين أنا رح يضل عندي remnants of the blood. يعني مو كل البلد رح ينزل passively. So the atria will contract عشان ينزل كامل على الventricle. طيب خلصنا the first part. فمتى الاتريال AV valves بيكونوا مفتوحين؟ When does it open؟ هاي كتير مهمة. Once the atrial pressure أعلى من الventricular pressure the AV valves they open. تمام؟ طيب بعدين what will happen؟ خلص هلا الventricles it gets filled up with the blood فالvalve it will close بس what will assure إنه the valve won't be everted يعني ليه ما يصير هيك؟ هون it comes the function of the papillary muscles and the chorditendina. So the papillary muscles imagine انتوا هون عندكم threads اللي هم الchorditendina, okay? And we have the papillary muscles. So the papillary muscles شو حتعمل؟ It will pull الchorditendina عشان هاي الvalve تضلها in its closed يعني position. It does not get everted. لأنه if it gets everted ما استفدنا إشي حيصير عندنا backflow. Is it clear؟ تمام. Then we have the semilunar valves. أنا قلت لكم شو؟ Remember إنه right ventricle مع مين؟ Pulmonary trunk and the left with the aorta. So we have pulmonary valve and we have the aortic valve. هون the semilunar valves they prevent the backflow of the blood to the ventricles. The AV valve it prevents the backflow of the blood to the atria. So نفس الشيء once the pressure بيكون أكتر بالventricles the valves will open. Okay? First step, where is the mitral valve? Left. Between the left atrium and the left ventricle. So what's the answer? Blood will backflow. Yes, correct. Another question. You took your cookies? Oh, okay. Type, who would like to? Yes.
The tricuspid valve is open and the bicuspid valve is also open.
Correct. Yes. Okay. In the valve problems we have two problems. Either incompetent or insufficient valve or the stenosis valve. The incompetent or insufficient valve the valve it closes يعني هيك بس بيكون عندنا like a hole. So still the blood can backflow up. Okay. And the stenosis valve أنا بيكون عندي narrow valve. شوفوا this is the normal valve. Once it opens very widely. If it's closed خلص it's sealed. But in the stenosis valve it opens يعني شوفوا بيكون it's narrow. Okay. Once it's closed it's not completely sealed. And it could result from high calcium or when we have a scar tissue. هاي السكار tissue بتصير لما what's the innermost layer of the heart? Endocardium. So بنصير عندنا inflammation endocarditis it will leave a scar tissue and it can lead to stenosis valve. And يعني the treatment إنه we can replace the valve but it should be chemically treated first. طيب question. Sarah. جاوبي. Yes. Who can explain to him why C is wrong? بالضبط. Did you understand ليه غلط؟ أكيد؟ Okay. هلا هون صحصحوا معي. So هون moving to the magic of the heart which is the circulation of the heart. Very easy, very simple بس يعني focus شوي. So إحنا أول شيء blood will get filled where? In the right atrium. from what يعني it will enter through the veins, superior vena cava, inferior vena cava, and the coronary sinus. The inferior vena cava, it drains all the blood from the upper part, the superior, sorry, and the inferior from the lower part. And the coronary sinus, keep it يعني for later. Then from the right atrium, it will go to the right ventricle. From the right ventricle, it will go to where? Pulmonary trunk. هلا pulmonary trunk, it will divide to the right pulmonary artery and the left pulmonary artery. The right pulmonary artery, it will go to the right side of the lung, والleft to the left side of the lung. وهون حيصير عندنا gas exchange. فالcarbon dioxide will be replaced with oxygen. Then it will go to the left atrium through the pulmonary veins. We have 4 pulmonary veins. We have 2 on the side and 2 on the right and 2 on the left. تمام. From the left atrium, it will go to the left ventricle, and from the left ventricle to the aorta. بعدين from the aorta, it gets distributed to the blood. هلا the same thing بس while mentioning the valves. So again, from the superior vena cava, inferior vena cava, it goes to the right atrium. من the right atrium لل right ventricle through the tricuspid valve. بعدين من the right ventricle لل pulmonary artery through the pulmonary valve. بعدين باللungs بصير عنا شو gas exchange. هلا now the blood is oxygenated. It goes to the left atrium through the pulmonary veins, and you have 4. Then from the left atrium to the left ventricle through which valve? Mitral valves. Then from the left, it's not tricuspid on the right. From the left ventricle to the aorta through اللي هو aortic valve. And then it goes to the rest of the body والcirculation بتاعته بتزيد. طيب هلا we finished the flow of the blood, but you have to know we have 3 types of circulation. We have the pulmonary, systemic, and the coronary. The pulmonary circulation, it starts from the right side of the heart and it ends in the left atrium. فإحنا بنبلش من the right ventricle, بنروح على pulmonary trunks, right to left, it goes to the lungs, بصير عندنا gas exchange, then it goes back to the left atrium. So the main function of the pulmonary circulation is to supply the blood with oxygen. تمام. السيستميك circulation العكس، احنا بنبلش بالleft side, we end up in the right side. يعني from the left ventricles it goes to where? Aorta. بعدين من aorta to the whole body, it supplies the body with oxygen, nutrients. بعدين نفس الشيء. Superior vena cava, inferior vena cava بياخذوا الأكسجين poor blood to the right atrium. طيب. يلا I need a girl to answer. مين؟ أنتي؟ لا. Oxygen referred returns from the body to the heart through the vena cava. Yes, correct. طيب the coronary circulation كل اللي شرحته كوم يعني عادي ignore it. هذا أهم إشي. This is the most important part. And a quick advice دائما بس تشوفوا إنه في هيك a page it's condensed with information حاولوها دائما like هيك a concept map أو أي إشي. يعني I remember I answered this question correctly لأن أنا عملت هاي الشخبط. We're gonna do it هلا together. طيب. So we said we have 3 layers of the heart, صح? Only the endocardium is in touch with the blood, تمام? So it's very hard for the myocardium, the thick wall, والepicardium إنه ياخذوا blood supply. That's why we have the coronary circulation. يعني it supplies the heart with the blood, تمام? From the base of the aorta, right here, بصير عندنا 2 arteries. عندنا the left coronary artery and the right coronary artery, تمام? The left coronary artery will subdivide to the circumflex artery and the anterior interventricular artery, and نفس الشيء right coronary artery will subdivide to the right marginal artery and the posterior interventricular artery. I'll draw it for you. Just give me a second. اعتبروه بريك قبل ما أخلص. طب هذا الخط واضح؟ Can you understand؟ يعني مين أحسن لكم هاد ولا هاد؟ This one? Okay. طيب. So we have the coronary arteries. كم من artery عندنا؟ 2. The right و left. The left one رح يعطينا anterior interventricular artery. Memorize the other name. It's very important. Left anterior descending artery. Okay, memorize both. The left side اللي هو anterior interventricular artery, the left anterior descending artery, it will supply two things. من الاسم anterior interventricular, ف it will supply the anterior walls of the ventricles and the interventricular septum اللي هو البارير. And then we have the circumflex artery. It supplies the left atrium كامل and the posterior part of the left ventricle. Okay. The right artery and the right marginal artery, it supplies the lateral side of the myocardium, and we have the posterior interventricular artery. Come on, from the name, it's very easy. Posterior interventricular, so the posterior walls of the ventricles. What else? You have to know in who it lies on the epicardium. It encircles the coronary sulcus. What is the coronary sulcus? Who can remind us? Between
the atria and the
Bravo. And that's it. طيب. هلا the heart is like any other organ. كمان احنا عندنا oxygen per blood. We have to take it back to the right atrium عشان ناخده على lungs to have gas exchange. How do we take it back to the right atrium? Through the veins. We have 4 veins. عندنا هون. Let's go back to this. عندنا 4 veins. عندنا الجريت اللي هو المين. We have the middle cardiac vein and this small, and we have the anterior cardiac vein. Okay, الجريت cardiac vein, it will drain كل البلد من from where? From the anterior interventricular sulcus, and the middle from the posterior interventricular sulcus, and the small from the heart's right inferior margin. هلا هدول مع بعض ال 3 veins, they will drain the blood to the coronary sinus اللي احنا حكينا عنه أول شيء. Okay, so from the coronary sinus it will go to the right atrium and it will follow the circulation. But the anterior cardiac vein, it does not go to the coronary sinus. على طول بياخد البلد لل right atrium. Is it clear? أكيد. The anterior. When? Right here. So the anterior cardiac vein ما بيروح على coronary sinus like the rest. Direct to the right atrium. Okay? طيب. So هلا you know يعني إذا coronary circulation صار لها أي مشكلة خلاص the heart it won't work normally لأنه it's the main blood supply to the heart. We don't have any other blood supply. فإذا صار عندنا blockage in any of the arteries ما حيكون عندنا oxygen to the heart, so حيصير عندنا الangina pectoris. Okay. هلا angina pectoris it could result from stress-induced spasm of the coronary arteries or increased physical activity. هلا one thing you have to keep it relaxed. يعني when the heart is relaxed, and I mean the ventricles are not contracting, they will be supplied with the blood. But if the heart is contracting, هدول الارتريز will be compressed, فما حيكون عندنا blood supply to the heart. فلما احنا هون يحكي إنه it can result from increased physical demands. يعني مثلا let's say imagine someone is running a marathon, فالventricles are contracting very hard. Okay, يعني ما في space, ما عندنا relaxation. That's why it can cause angina pectoris. إذا صار عندنا prolonged coronary blockage, it can lead to the myocardium infarction, which is the heart attack. How do we differentiate between angina pectoris and myocardium infarction? Cell death. In angina pectoris, the cells are not affected. يعني the cell does not die. In the myocardium infarction, the cells dies, and you know the cardiac cells are amitotic. يعني if it dies, it cannot be repaired normally. That's it. It will leave like a non-contractile scar tissue. Who would like to answer? Yes, sure. Is it clear now? I can read it for you, Adi. لا, someone new. Sarah. A 40-year-old male present to clinic with chest pain. After examination and investigations, the doctor described the pain as angina pectoris. Which of the following is true regarding the case? Someone new. Yes. The demands of myocardium being unable to, yes, correct. Yalla, other question. From the back. Yalla. Yes, which of the following is the explanation of angina pectoris? شو يعني angina pectoris? Angina pectoris. Sorry? The previous one, it was D. Okay. Wait, he wants to answer. Oh, we have a girl. Yes, answer. Heart relaxation, yes. لأنه we said in the coronary circulation it works when the heart is relaxed. تمام? One more question. No. Someone new. Yes. Yes, correct. We said in the great cardiac vein والmiddle والsmall, they drain the blood to the coronary sinus, while the anterior directly to the right atrium. تمام? And مين اللي smart will answer this hard question. Matching question. Take your time. فكروا. عم بصير في debates. Who's ready?
The middle vein accompanies a branch of the left coronary artery.
Okay.
The great vein
Who can help?
Oh, sorry. The middle vein, posterior aspect of the atrioventricular groove.
Okay.
The great vein accompanies a branch of the left coronary artery. Small vein, right inferior margin of the heart. And the coronary sinus accompanies a branch of the right coronary artery.
Who agrees? ولا حدا? Repeat your answer. Guys, focus. Is his answer correct or wrong? Repeat,
Middle
please.
vein is D.
Okay.
The great vein is
أكثر من هيك؟
the great vein accompanies a branch of the left coronary artery.
Is it DBAC?
لا mention them واحدة واحدة عشان نمشي معك.
Middle vein.
Okay.
Posterior aspect of the atrioventricular groove.
Okay.
Great vein accompanies a branch of the left coronary artery. And then small vein accompanies a branch of the right coronary artery. And then coronary sinus, right inferior margin. دي أول صح؟
طيب. The correct answer is in the middle vein, it's with the posterior aspect of the atrioventricular groove. The great vein, it accompanies a branch of the left coronary artery. The small vein, the right inferior margin of the heart, and the coronary sinus accompanies branch of the right coronary artery. This was your answer, صح? Yeah. Where's the cookies? Yes, in the middle vein. Okay, guys. Small note. And no, the middle vein, it's between the interventricular, not the atrioventricular. تمام? Is it clear? طيب. And I don't know if you checked the important group. I promised إنه أي حدا will attend. I'll airdrop you my notes for anatomy. So open your airdrops.
Okay, guys. So Jude did an amazing job. I think we all think the same. She did excellent explaining the anatomy. So now it's my part to explain the physiology, start of the physiology. My name is Yazan Yasin, and I'm gonna explain the electrical activity of the heart. So basically, starting with the intrinsic conduction system. You know, guys, that your heart beats by itself. You're not controlling your heart beat. So how does this happen? Through the intrinsic conduction system. The activity of the heart is coordinated and independent, and this is a function of two things: the gap junctions. You took the gap junctions in Bio 1, and also the intrinsic conduction system. We're going to talk more about them in detail after a few slides, and also it initiates and distributes impulses throughout the heart. This is the function of the intrinsic conduction system. It also consists of pacemaker cells, which are autorhythmic. We're going to talk about them here. Okay, so the action potentials by the pacemaker cells. So these pacemaker cells, the difference between them and the normal contractile cells of the heart are basically that the normal contractile cells of the heart has a stable membrane potential, stable resting potential, while the 1% of cardiac fibers, they are called the autorhythmic, the pacemaker. We're going to be talking about them a lot now. So basically they have an unstable resting potential and they spontaneously depolarize. That means no external stimulus is required. Okay, so they have their own potential called the pacemaker potential. What is the pacemaker potential? I'm going to show you a graph right now and I'm going to explain it. Basically, it keeps going toward the threshold and it initiates the action potential that's spread throughout the heart. Okay, so this graph is very important because it's talking about the pacemaker potential. Pacemaker potential starts with here. We're going to start by step 1. Can you guys see? Okay, so step 1, pacemaker potential. Why does the pacemaker potential happen? It is due to the opening of sodium channel, Na, okay, and closing of potassium. So it's going from negative toward the positive, toward the threshold. After the threshold, what happens? We have number 2, depolarization. So the action potential begins when the pacemaker potential reaches threshold. So after it reaches threshold, the action potential begins. Action potential is due to what? It's due to the calcium. Depolarization, it keeps depolarizing and then goes toward that action potential due to calcium. So if a question was, is depolarization in the pacemaker potential or in this action potential of the pacemaker, like is the depolarization due to sodium or calcium? Calcium. Don't mix it up because that's the skeletal muscle, okay? So then number 3 is repolarization, where it goes back to the negative side. It is also due to calcium channels but inactivating, closing. And then the potassium channels open, so it goes back toward negative. This allows potassium efflux, which brings the membrane potential back to its negative voltage. Did everyone understand? Okay. Okay. Sequence of excitation. This is where we get into the important stuff. We start with the sinoatrial node, which is a pacemaker cell. Okay, it is autorhythmic, like I said. So we start with the sinoatrial node, then go to the AV node, then go to the AV bundle, then go to the bundle of His, then to the Purkinje fibers. So there is a sequence of excitation. It's going from one place to another, following it. We're going to talk about them in detail. Okay, starting with the sinoatrial node. First of all, what is the sinoatrial node? It's a pacemaker cell, right? So where is it found? It is found in the right atrium. Where exactly? Inferior to the vena cava, okay? And it does 75 beats per minute. So this is very important for the sinoatrial node, to know that how many beats per minute, and for each node. Then we have the most important function of the sinoatrial node is that it sets the basic rhythm of the heart. Basic, like if you talk about the sinus rhythm, it's the most important, since it starts the sequence of excitation. So that's about the sinoatrial node. After that, we have the atrioventricular node, okay? Also, it's important because it has a special function. It delays. It has a 0.1 second delay. So, going from the right atrium inferior to the vena cava, then the impulse is spreading toward the AV node. The AV node then connects it to the ventricle. So this is very important. Why? Because it's relaying from the atrium to the ventricle. It's between them. So where is the exact location of it? It is superior to the tricuspid valve. Okay? And also it is inferior to the interatrial septum. What is the interatrial septum? The one that divides the right atrium from the left atrium. Okay? Also, the book explained it as if you had traffic. You had 4 lanes. You're going by car. And then it became 2 lanes. So this is the delay. It was 4 lanes, the road is okay, and then بعدين صار 2 lanes, فصار زحمة أكتر. فهيك صار نفس الشيء. كأنه أنت رايح من sinoatrial node toward the AV node. It causes a delay. This is the most important thing about the AV node. Third of all, we have the bundle of His. Bundle of His main function is it connects. Also, going from the sinoatrial node, then to the AV node, then to the bundle of His. Here, it's connecting. It goes through the interventricular septum, and it is the only electrical connection between them, between the atria and between the ventricle. Here it says that the cardiac skeleton is insulating. The only way for an impulse to pass from the atria to the ventricle is through the AV node and bundle. So this is the only way it can go from sinoatrial node, then AV node, then the bundle of His, because the cardiac skeleton is insulating. Then you have the right and left bundle branches. So it goes, one goes to the right and one goes to the left from their name. It's easy. Simple. It goes through the interventricular septum toward the apex. The apex, Jude already said that the apex is here, pointing toward the left hip. Okay? Then we have the Purkinje fibers. These are very important. I remember they used to get questions about them. So what are the Purkinje fibers? They are fibers that are going toward the atria, from the apex toward the atria. This is very important, guys. Please know that it's going from the heart apex toward the atria. So the depolarization went from the sinoatrial node, AV node, bundle of His, right and left, and then Purkinje fibers. Okay? Total time between initiation of an impulse by the SA node and depolarization of the last is 0.22 seconds. So this thing we talked about from here to here takes about 0.22 seconds. Okay. We have a question here. حد جديد؟ Okay, you didn't answer, right? Okay.
B.
Okay. Correct. It goes, like we said, it goes from the right atrium and then go down. Okay. Another question. تفضل. شو؟ D? Okay, صح. لأنه we said that the Purkinje fibers from the apex, heart apex toward the atria, like I told you. That's why I said it's important, because we got a question. Okay. Easy question. في حد جديد؟ اوكي عاد رافع ايده صار له 3 اسئله. تفضل. لا. B صح. B لانه we didn't mention anything about skeletal muscle. It's cardiac myocytes. بس يعني good guess عادي. It's fine. Okay. Okay, this is a special action potential. We talked about it. Okay. You answered right?
I answered with her.
Okay, it's fine. Answer.
A.
Okay, that's correct. We said that the pacemaker cells have their own potential. It's called the pacemaker potential. Okay. Okay.
C.
Okay, does anyone think that's correct? Anyone has another answer? Exactly. Because me myself, when I read the question, I got it wrong. Because basically they're next to each other, right next to each other. But the one that goes from the atrium and connects it, relays it to the ventricle is the AV node. Okay. Guys, this is very important. I think we got a lot of questions from it. The SA node, normally it has 75 beats per minute. I already told you guys this. Then let's say the SA node stopped working. Who will take over? Who's next? AV node, right? So the AV node, how many times per minute? 50 beats per minute. Okay, so it might not be enough, it might be enough. It depends. But usually it's not as good as the sinoatrial node, because the sinoatrial node is the basic basic rhythm. Okay, then if the AV node stopped working, sinoatrial node ولا AV node, الاثنين خربوا. شو عندنا؟ ايوه بالضبط ال AV bundle and the Purkinje fibers. These have 30 beats per minute. They beat 30 times. Okay, and this is not enough usually. Note that these slow pacemakers cannot dominate the heart unless fast pacemaker cells stop functioning. They're not enough. Okay, to the bulk. الهوميوستاتيك امبالانس هذا شوي ركزوا معي لانه هذا مهم كثير بيجي عليه كثير اسئله. The homeostatic imbalance بيحكي لك انه the irregular heart rhythms are called arrhythmias. They're not regular. They're not the same as the usual heartbeat. Okay? They also cause uncoordinated atrial and ventricular contraction or even fibrillation. I'm going to go step by step because I don't want to miss anything in the homeostatic imbalance. They can get anything. Okay? So, uncoordinated atrial and ventricular contraction causes fibrillation. What is fibrillation? شو يعني? A condition of rapid and irregular or out of sync contractions in which control of the heart rhythm by the SA node, because SA node is the first one, is disrupted by rapid activity in other heart regions. The heart in fibrillation has been compared with a squirming bag of worms. It's very irregular, it's weird. The heartbeat is not beating the same as it usually does. So it's been compared to a squirming bag of worms. What's the solution? How do we fix this? Defibrillation. You've seen in the movies how they do this and then they pump it. This is called defibrillation. Okay? So it is accomplished by electrically shocking the heart, which interrupts its chaotic twitching by depolarizing the entire myocardium. It cleans the state, like wipes the state clean. Okay? And then we have the implantable cardioverter defibrillator, ICDs. These are very important because they can continually monitor heart rhythm and slow an abnormally fast heart rate or emit an electrical shock if the heart begins to fibrillate. So if the patient has a very fast heartbeat and you put the implantable ICD, you implanted it in his heart. If he has a very slow heart, if he has a very fast heartbeat, it will slow it down. If there is it will emit an electrical shock if it's also very slow. فthis helps the patient. This is a picture of the ICD here. This is where they implant it. It goes through the vein and toward the heart. Okay, so we have also a continuation of the homeostatic imbalance. Let's say we have a defective SA node. It's called ectopic focus. Ectopic focus is very important. Why? Because it says that an abnormal pacemaker may take over the pacing of the heart instead of the SA node. Why? Because the SA node basically paces the heart. It's the normal thing. Okay. If the AV node took place, we said before a bit that the SA node might not work and the AV node might take place. And the heart beats how many times? 50 beats per minute, exactly. So it's said here 40 to 60. This is called junctional rhythm. Basically, it's when the SA node stops working and the AV node takes place. When the AV node takes place, you'll have 40 to 60 beats per minute, which is slower than the sinus rhythm, which is the 75 beats per minute. But it can still maintain adequate circulation. Okay, also this is very important. We also got a question about it. If the SA node is working normally, but you can still find an ectopic pacemaker, what might this cause be?
Mature contraction.
Yes, exactly. It's due to too much caffeine or too much nicotine. Sometimes when you drink a lot of caffeine or something, you can feel your heart, it's beating in a weird way. So this is basically the problem. Too much caffeine or too much nicotine, a small portion of the heart becomes hyper-excitable and this generates impulses more quickly than the SA node. So some place in the heart will start generating more impulses than the SA node. So this causes premature ventricular contraction. Okay, this is the name, PVC. Okay, they are usually harmless, but if they are persistent, then they require evaluation. Okay. See, I told you guys we got a question. نظارات. نعم. أنت أزرق. إيه؟ أوكي ما سمعتك. أوكي صح كلامه صح لأنه we said إنه PVCs due to too much nicotine or caffeine. Okay. Okay. Partial heart block and complete heart block. These are also very important. So we said that the cardiac skeleton is insulating, right? So the only way the impulse goes from the atrium to the ventricle is through the SA node, then the AV node. Okay? So if this SA node is not, it can't send the impulse to the AV node, what will happen? The receiving part is damaged basically. It will cause heart block. Okay, what's the difference between partial heart block and complete heart block? Is basically the partial heart block, what happens in complete heart block, no impulses get through and the ventricles beat at their intrinsic rate. Okay? Solution, what do we have? What do? We said fibrillation, defibrillation. Here, artificial pacemaker. They are implanted to recouple the atria to the ventricles. So then the impulse can reach from the atria to the ventricle. Did you guys understand the partial and heart complete? Okay. Okay, we talked about the intrinsic conduction system. Now we're going to talk about the extrinsic. We said 1% of the cardiac cells are pacemaker. What about the rest? They are contractile cardiac cells. Okay, so basically, how do we differentiate between them? The intrinsic conduction sets the basic rhythm, while the extrinsic march like beat and variability from one beat to another. This can be one difference. The sympathetic, okay, this does not have to do with it a lot, but it's important because there is a figure that explains it. The sympathetic nervous system, it's extrinsic, right? So it's controlling the heart as well. Also the parasympathetic. So sympathetic is fight or flight, and parasympathetic is rest and digest. So which one will be cardio-axillary center? Sympathetic. And the parasympathetic, rest and digest, so slows the heart. This is the figure I'm talking about. Okay, the cardio-axillary center goes to the T1 to T5 in the spinal cord and then goes to the heart, while the cardio-inhibitory center goes through the vagus nerve, parasympathetic, and it decreases the heart rate. So sympathetic, axillary, and then the brakes are the cardio-inhibitory through the parasympathetic. Okay? Okay, it has its own graph, the same as the intrinsic conduction system. The extrinsic, the difference is basically that we said in the intrinsic the depolarization is due to the calcium, exactly. Okay, so here depolarization is due to sodium, not due to calcium. Okay, so it depolarizes, goes from negative to positive through the opening of Na channels, sodium. A positive feedback cycle rapidly opens many sodium channels, so positive, it's opening. Okay, and then we have the plateau phase. What is the plateau phase? Basically, calcium also plays an important part here, but how does it happen? احكوا عندكم مي والمي فتحتوا الحنفية وطلع كتير مي، بعدين سكرتوها صار ينقط نقطة نقطة نقطة. هذا هو الكالسيوم، بلش يسوي ديبولارايز على الخفيف، نقطة 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 نقطة. ليش؟ مشان يطول الديبولارايزيشن. Okay, so this keeps the cell depolarized because most potassium channels are closed. They're still closed. بعدين in repolarization, what happens? Exactly, closing calcium, opening potassium. Okay, so repolarization is due to calcium channels inactivating and potassium channels opening. Efflux, the potential goes down to the negative side. Okay, ECG. What is an electrocardiogram? Basically, it is a graphic record of heart activity. An ECG is a composite of all the action potentials generated by nodal and contractile cells at a given time. This is not very important, but this is very important. Okay, so we said that the SA node goes from the right atrium, right? I'm gonna tell you guys each wave and what it does. For example, the P wave. What does it do? It's atrial depolarization. You guys just have to memorize this because they get a lot of questions about it. Okay? So, atrial depolarization initiated by the SA node. So the SA node sends impulse to the AV node. Okay, what does this cause? Atrial depolarization. So atrial contraction almost. Okay, and this causes the P wave. Then after the P wave, here it went to the AV node. What happens? Atrial depolarization is complete. Okay, the impulse is delayed at the AV node. 0.1 second delay we talked about. Okay. Now we have the QRS complex. This is very important because what happens here is ventricular depolarization, while in the P wave, atrial depolarization, right? Okay, I wrote here that the atrial repolarization is not shown because it was mentioned in the book. Why is it not shown? Because the ventricle is bigger than the atrium, so the depolarization will cover the repolarization of the atrium. Okay? Then, after the QRS complex, we have the T wave. T wave is very important because it is the ventricular repolarization. Okay? Before the T wave, the QRS complex ventricular depolarization. Atrial repolarization. P wave atrial depolarization. But after the QRS complex, depolarization is done. T wave, exactly. Ventricular repolarization. لأنه if the ventricle is big, so the wave shows if there is repolarization. And after the T wave, of course, the ventricular repolarization is complete. Okay, guys, this is a picture of an ECG. Okay, and I want you guys to tell me what's this? What's happening here? Can you tell me each wave and what do you think the problem is? Exactly, normal sinus rhythm. Because why? We can see here, this is P wave, this is QRS complex, and this is the T wave. Okay? So everything is normal. I did some things, ما كثير مهمين, بس بيساعدوا. Okay, and then we have this thing. ما شاء الله. كيف عرفتوا؟ Exactly. ما في P wave. P wave is absent. لأنه P wave شو? Is the SA node. SA node goes to the AV node. So if the P wave is absent, then the SA node is non-functional. Who takes place? AV node. Beats at their intrinsic rate, which is 50 beats per minute, or 40 to 60. Okay? Second degree heart block. I explained the second degree heart block as some of the impulses reach, right? So what's happening? You can see here, there are two P waves. Why?
Because the SA node is working, it's not able to generate.
Exactly. لأنه ال SA node is trying to send an impulse, but it's not reaching. The receiving part is damaged. So after sending more than once, okay, it took it. The AV node took the impulse. What happens? We can see two P waves. That's how you know it's what? Second degree heart block. Okay? طيب, we said إنه fibrillation is like a squirming bag of worms. صح? Exactly what we said. You can see it's very irregular. You can't see the P waves, you can't see anything. This is fibrillation. Okay? We use a defibrillator. Okay. Guys, let's say the QRS complex was like elevated. Okay, the R wave, which is at the top, was elevated. What does this mean? What happens during QRS complex?
Ventricular depolarization.
Exactly, ventricular depolarization, so almost contraction. So this causes hypertrophy. The ventricle is enlarged. So enlarged ventricles. This can come as a question, by the way. You'll get enlarged R wave or QRS complex. It's usually ventricular hypertrophy and enlarged ventricles. Okay? Now we have two important things. They are called the ST segment and the PR interval. ST segment is basically when the whole entire myocardium is depolarized. Okay? Memorize this, guys. Whole entire myocardium is depolarized in the ST segment. Okay, and then the QT segment is from the beginning of ventricular depolarization to repolarization. Why? Because Q here starts and then QRS, ventricular depolarization. بعدين T, repolarization. So this is what the QT segment means. Okay? We have problems with the ST segment and the QT segment. What are these problems? Basically the book, guys, الكتاب ما شرح منيح كتير عن هالموضوع، بس ألكم إنه احفظوها هيك يعني. اوكي، حتى لما شرحها شفتوا ما كثير ركز عليها، بس انه هي كثير مهمه لانه حيجيبوا سؤال عنها، بس ما ركز على شرحها. اوكي، احفظوها حفظ، بس احاول انا افهمكم. عندك ال ST segment we said the whole entire myocardium is depolarized، صح؟ Okay, so if the ST segment is elevated you're gonna find the bump here. Okay, what does this mean? If it's elevated then it's myocardial infarction. طب what if it's depressed downwards? It will cause angina pectoris. Jude explained it. Okay, so and also ST segment if elevated or depressed will cause cardiac ischemia. Okay, this is very important. Okay, and prolonged QT segment, repolarization abnormality. Repolarization, guys, focus on this. Prolonged QT segment, repolarization abnormality, which increases the risk of arrhythmia. So, okay, I'll test you guys. Elevated ST segment. عادي هذا مو myocardial infarction, ischemia. Okay, طيب depressed angina. Okay, prolonged QT arrhythmias, exactly. Okay, so what I understood from this is basically what happens. The ventricle in the ST segment, elevated ST segment, is trying to contract, right? The contraction, when it tries to contract, it's causing the capillaries to narrow down, so they become narrow, and this stops the blood flow. This is what I understood what they mean by cardiac ischemia. Okay, we have some questions here. The things I just explained, they get a lot of questions about, focus on them. تفضلي. صح, second degree. لأنه more P waves. We explained إنه if there are more P waves, then it's second degree heart block. The SA node is trying to send the impulse, but the receiving end is damaged. Okay. شايفين؟ اوكي. الشب بي صح. لأنه we said إنه elevated ST segment, myocardial infarction or cardiac ischemia. So this is the answer. Why is it not C? Exactly. Repolarization abnormality. Okay? Not depolarization. Okay. Is not. Okay. صح. لأنه T wave is what? Ventricular repolarization. Okay. Okay, another question. هاي correctly matched, هذيك not. Okay, تفضلي. صح. A because the QRS complex is ventricular depolarization. Okay. ركزوا على آخر كم من كلمة. C? صح. We said that the ST segment, the whole entire myocardium is depolarized. جاوب. صح لأنه if the blood pressure is too low, you need the heart to pump more, become faster, so the blood pressure goes up. So this is through, okay, and sympathetic, okay. هالعكس هذاك كان low blood pressure هاد high. اوكي الشاب الكندوره لابس كندوره. نعم صح. ليش؟ لانه الباراسمباثيك it slows down the heartbeat, it's the brakes, okay? So it causes the SA node, cardiac plexus, SA node, AV node, okay? ولانه SA node because the SA node is the base, sets the basic pacing of the heart, okay? Okay, we have تفضل.
What do you guys think if we have a small break? Would that be better or should we continue this small break? Guys, what do you think? Should we have a small break?
Yusuf, I just have two pictures more وبعدين Samer's part. So I can finish and then they can take a break.
After this part, we'll take a 10-minute break, okay?
Okay. Okay, guys, I'm gonna explain the cardiac cycle really quickly because Jude already explained like half of it. Basically, the pressure is important here. It goes from high to low. So, at the beginning, Jude said that the gravity, 80% of the gravity takes the blood through the atria, through the tricuspid, and then the atria contracts the 20% left, and then you have the ventricle filling, okay? So these are the pressures. This is what happens. But the one thing I want to focus about is the isovolumetric contraction and the relaxation, because they get questions. Isovolumetric contraction phase. What is it? It's basically when you see the question and you see the isovolumetric contraction phase, just look for all the valves are closed. Okay? This is the most important thing about it. Okay, basically here in the picture you can see it in a better view. Here, look, the ventricle is filled with blood, right? So if the ventricle is filled with blood and the valves are closed, this is isovolumetric contraction phase. And then the relaxation is basically when the ventricles pump the blood, okay, and then it goes back. The blood goes back and closes the semilunar valves. Okay, this is the relaxation phase, isovolumetric, because also the tricuspid still is not all the way open, it's still closed, and the semilunar valves are also closed. For all the valves are closed in both of them. Okay, and something I also want to focus about is the dicrotic notch. What is it? It's basically when the blood rebounds at the semilunar valve. Okay, you ejected the blood. It went through the vessels, but it goes back. When it goes back, it closes the semilunar valve. Okay, when the semilunar valve closes, it causes the dicrotic notch. Okay, this is important as well. Samer is gonna explain the heart sounds. End diastolic and end systolic. Basically, the end diastolic volume is at the end when the heart is relaxed and the ventricles are filled, while the end systolic is contracting. So after contraction, the blood that is left in the ventricles is the end systolic volume. Okay? Okay, isovolumetric contraction is حكيت لكم على السريع دوروا على شيء معين. Exactly, لأنه are completely closed chambers. But just look for completely closed. Okay? خلاص, I'm done with my part. Thank you very much.
Alright, hello everyone. My name is Ameer. I'll be explaining the last part of the heart chapter. I know you've been here for a while, but Once this part is over, you'll feel like you've mastered this chapter, okay? This part needs a bit of understanding, but it's all right. I'll start with an easy one, which are the heart sounds. Now, for the heart, we have like 2 sounds, then a pause. Lub, dub, pause, and then repeat till you die. For lub and dub, we need to ask 3 questions, always. How are they made? When are they made? And finally, what is the sound itself? All right? For lub, how is it made? It's by the closure of the atrioventricular valves. I guess you know them all because they explained them. It's between the ventricle and the atria, all right? When does that happen? At the beginning of the ventricular systole. Precisely whenever the ventricular pressure is higher than the atrial pressure. You already know this, so I won't take too much time. What is the sound? It's loud and long. It's lub, starts with an L, long and loud, they also start with an L. So you could remember that. Will they get that in an exam? I doubt it. But just know it. Dub is the second sound that you could hear. It's made up by the semilunar valves when they close. When do they close? Beginning of the ventricular diastole. In a bit we said ventricular systole, now it's different. It is diastole. What's the sound? It's short and sharp. Should you know it? I don't think so. So I'll skip through this part. Pause. This is very, very straightforward. It's during diastole. All right? We're finished with the sounds. But what's the benefit from knowing these sounds if we can't find them? What we do is search for them in surface anatomy. But before, I need to ask you a question. The pulmonary valve, is it right or left? The location? Right. We can all agree. But where could we hear it? Left. So the upper valves, the semilunar valves, the big ones, they're heard in the opposite side. If they're right, they're heard on the left. If they're left, they're heard on the right. That doesn't apply to the lower ones, the atrioventricular. So look at this picture. Now, most pictures on Google says one thing and your book says another. Let's focus on the upper valves, the semilunar ones. In our rib cage, we have many intercostal spaces. I don't want you to know any of them except 2, second and fifth. Semilunar valves are all in the second intercostal space. In relation to the sternum, the bone right in the middle, you can all feel it. Right to it, you will feel the aortic valve. Left to it, you will hear the pulmonary valve. As I told you, they are switching sides. Now, if you go down for the atrioventricular valves, your book does not follow this picture. The tricuspid valve, which is on the right, is still on the right. In the fifth intercostal space, just right to the sternum. What about the mitral valve? It's kind of autistic, and it does not love the sternum. It's very far away from it. In the same intercostal space, fifth one, but in the midline of this yellow bone, which we call the clavicle. In a year, you will study this for 3 hours, just this single bone. So at the moment, it's easy. Just the midline of this bone, all right? We know what they are, where they are. Now, by the way, this is a side note. I don't know if they will bring it, but you can hear the mitral sound before the tricuspid and the aortic before the pulmonary. Anyway, now things could go wrong. Normally, the blood flow silently. Blood flows through these valves silently, nothing is there. But if it goes wrong, what happens? You hear heart murmurs. Jude talked about 2 types of valves. Insufficient, yani they're not closing properly, or stenotic, all right? For the insufficient, what will you hear? Swooshing sound. What is swooshing? I have no idea. You have to hear it on your own. But remember the word insufficient to swooshing. What about the other? Stenotic valve. It should be open, but it's not getting opened enough. It will make a high-pitched click. Remember, swooshing with a valve that does not close, so blood flows back. A high-pitched click with a stenotic valve that's supposed to be a bit more open. Yalla. During a cardiovascular, you could read the question, system examination of a 56-year-old patient, the doctor was suspecting a stenotic tricuspid valve. Which of the following is best? Say it loud and clear, and let's all hear it.
Left fifth intercostal space.
Does anyone have another answer?
Right foot. Right foot.
Correct. As I told you, our book is kind of like against the others. It's on the right here, on the right. Let's see it. Here, it should be on the right. I chose this picture in specific to tell you that they're both technically right, but according to the book, fifth intercostal space to the right. All right? I think we're done with the sounds. Now, the sounds you'll be asked in the exam, you'll be asked about the sounds, but for this moment, forget about them. Because this part is, in my opinion, the most interesting part in the whole chapter. And I've heard from some students they're having some difficulties with it. You studied the structure of the heart, and you studied the physiology of the heart. But what's the benefit from studying these parts if you don't know how well the heart is performing? The heart is an engine, like a car engine or an airplane engine. To know its performance, you have to study its output. And in this case, we will call it the cardiac output. All right? What is it? Keep focused, stay focused, yani. For every single heartbeat, a small amount of blood is ejected from the heart. This amount of blood, let's all agree to call it stroke volume. Is this the cardiac output? It's not. Still, we're talking about a single heartbeat, the blood is ejected. What is that group of blood? Yeah, a small pinch of blood is stroke volume. If I start a 60-second timer, obviously, 60-second timer, what will happen? Another heartbeat, and another, there isn't only one, and another, and another. We're collecting stroke volumes, and more, till we collect it in a jar. This amount of blood collected in the jar is what we call the cardiac output. Is it clear? In the beginning, we have only one pinch of blood, which is the stroke volume. If we start a 60-second timer, there will be more and more till we collect this amount of blood in a jar. This is called the cardiac output. All right? From here, we can find two factors that play around with the cardiac output: stroke volume and heart rate. And this is very logical. I'll tell you why. Stroke volume, imagine a heart that gives you this amount of blood for every ejection, for every heartbeat, versus this amount. Me and you, we can all agree that after the 60 seconds, the second one will have a higher cardiac output. So the stroke volume is one factor. The second one, heart rate. Imagine this amount of blood or this amount of heartbeats happening within the 60 seconds versus this. The second one will have a higher cardiac output. After the 60 seconds, we will manage to collect more blood. So these two factors allow us to have a variable cardiac output. You know this guy? He tried to be the president of USA. Yes. He's just like you at this moment. He's resting. Yeah, like 4 to 6 liters at the moment. You guys, you have like 4 to 6 liters of cardiac output. But if you suddenly hated this lecture and you started running, you'll be having around 25 to 35. 25 if you are not fit, 35 if you are. The difference between these two states, resting and active, is what we call the cardiac reserve. All right? You might be asked a question in the exam. They say cardiac reserve. You shouldn't be lost. You should remember it's the difference between these two states. How do we go from 4 to 25? We play around with these two factors that I mentioned, stroke volume and heart rate. Keep this in mind. I'll start talking about the stroke volume first. All right. Now, stroke volume, I want you to remember this definition that I mentioned. And it's the amount of blood ejected after every single heartbeat. And keep that definition with you and make it the first. Everything else I say is like secondary to it. But another definition is end diastolic volume minus end systolic volume, which is, by the way, 120 minus 50. Now, let's see this picture. This is the end diastolic volume. It's like this room filled with people, or in case of the heart, it's filled with blood. Let's say I'm the heart. My job, my dream job, is to kick people out. I'll have a maximum EDV. I'll fill out this room and then kick as much people as I can to keep the ESV low. The amount of people I kicked is what we call the stroke volume. You get the idea? I filled the room, this is the EDV. I filled my heart ventricle. If I manage to kick many people out, I'll have a low ESV. And that's what we wish if you wanted to have a high stroke volume. All right. We need to know what affects the EDV and the ESV in order to see what affects the stroke volume. Simple as that. All right? Yalla. Let's start with the EDV. EDV and the word venous return is almost the same thing. The amount of blood coming from the veins into the heart, venous return. It's affected by three things. Let's mention one by one. And you should not memorize them. You should understand them fully. First is venous pressure. Let's say this room, by the way, this room will be the ventricle like for next 10 times. Let's say this room is the ventricle and people are trying to come in. If they're excited, PACademia, Osama, Ameer, they're trying to push each other, they will run. Versus a group of people, they are lazy. They cannot even walk. Will I fill the room with the lazy people or with the ones that are pushing each other? What do you say? Pushing, obviously. If they're very excited, just like the case of the ventricle. If the veins, they have a high pressure, the blood is rushing in, it will be filled much more easier. And that's the EDV. Secondly, diastole duration. Same room, ventricle. If I keep the door open, I'll give those people some time to enter. But if I close it very quickly, they won't. And that's the same case for the heart. Its doors are the valves. If they keep closing very quickly, I cannot fill the heart up. The third one is exercise. And this is basically, we learn it more in blood vessels, but during exercise, your muscles are all working hard. They will squeeze the veins, so the blood will go from the muscles into the heart. And it will also activate sympathetic system, but just remember these and understand them. The ESV. As I told you, I'm the heart. I try to kick people out. People came in and now I need most of them to leave, aka the blood. I want most of the blood to be ejected. So I need to be good at pushing. I need to be good at contraction. So the more contraction I have, the lower the ESV. I want a low ESV in order to have a higher stroke volume. But one thing could act against me, and that's the afterload. Now the afterload, imagine people are leaving from this door. I'm actually pushing them, they're not leaving, I'm pushing them. And there are like 1,000 students standing right after the door. And they're also trying to enter. What will happen? It will be harder for me to push. As much as I push, there are people there that are also trying to enter, it will be hard. So if there is a high arterial pressure in the aorta or the pulmonary artery, it will be harder for me or harder for the ventricle. All right? I'll be covering the contraction, arterial pressure, and also a big guy that I did not mention, the preload. I'll cover them a bit more deeply. All right? Now, the preload. So this guy and this other guy, they decided to make a law, call it the Frank-Starling law. And it just states that the preload is related to the stroke volume. Why do I have this in here? Because 1 year ago, I had the exact same question in the exam. Frank-Starling law is connected between what and what? Stroke volume and preload. But what is preload? Preload, remember, directly connect the word preload to the word stretching. It's the degree to which cardiac muscle is stretched before contraction. If we have preload, it means that the muscle has stretched. Now, you guys pass by one. I'm guessing you're taking by two. You pass by one. You remember this picture, right? Myosins and actins, cross bridges, right? Well, every muscle, it has a dream. Its dream is to have the optimal length. In the optimal length, cross bridges are maximum and the contraction force is maximum. For our skeletal muscles, for example, the bicep, its normal length is its optimal length. So it's almost always in its dream. The cardiac muscle, subhanAllah, it's not the same case. It's a bit shorter than the optimal length. So it needs something to stretch it, something to fill it up to reach its optimal length and be the strongest. So what is that thing? It is the EDV. If we have a high EDV, you will fill the ventricles, they will stretch, and you will have the actual preload that you wish you had. All right? Preload is done. Two more things. Contraction. They call it contractility, and it is the contractile strength at a given muscle length. You should know this. Given muscle length. These two, wait, hold on. These two are in the same exact length. They are the same. I was just talking about length and why is it important. They are the same length, but one could have a higher contraction than the other. And what is the reason behind it? Does anyone know? Why could two same exact lengths have one of them could have a higher contractility? Yeah, cross bridges, but the actual thing is calcium. If you have more calcium, equals more contraction. So anything that comes from outside of the heart, that we call extrinsic factor, anything that comes from outside of the heart and increases the calcium within the muscles will increase the contraction no matter the length. سواء كانت في الoptimal length, ما كانت في الoptimal length, it will increase. Alright, what are these things? To be honest, I don't want you to remember them during the lecture. I doubt that you will. What I want you to remember, sympathetic system increases contraction, because in a few minutes I'll mention it as a compensation method. I'll mention it. We call them positive inotropic. If they increase the contraction, we call it ino. And here are the things. I made a mnemonic that says the cool guy digs calcium. If you want to remember it, you could. If you don't, you don't need to in this lecture. But just remember, thyroxine, catecholamine, glucagon, drug digitalis, and high calcium levels. We said calcium increases contraction. If we have high calcium levels, that's a good sign. Over here, negative inotropic. What would affect it? Acidosis, more potassium, and calcium blockers. Calcium blockers, إذا واحد غلط بالامتحان حزعل يعني. Calcium blockers is obvious. Calcium increases contraction, and if we block calcium, no contraction. صح? Easy. Now the afterload, it's simple. In the aortic artery, the pressure is around 80 millimeter mercury. In the other one, it's around 10. But we don't worry about it because it's usually does not affect the ventricle. The ventricle is strong enough. But this one is our biggest fear, almost the fear of like a quarter of the population. Because when they have hypertension, it's like people trying to enter from the exit door, and it will just make it harder for the ventricles to contract. A higher arterial pressure means our ESV is high. I could not kick people out because it's very hard for me. A lot of people will stay in the lecture. A lot of people will stay in the ventricle. Blood يعني more people. So the stroke volume will be lower. واضحة الأمور؟ Preload, contraction, afterload. All clear? Good. Yalla, a question. After running to catch a bus, a young man noticed that his heart was beating faster than normal. An increase in which of the following factors might have led to an increase in the cardiac output in this person? صح. Venous return, the muscles will squeeze the veins and more blood will be led to the heart. Easy? حلو. We told you. تفضل.
ليه الإجابة برضه ما تنفع دي؟
أي واحدة؟
دي برضه.
Blood شوف يعني blood calcium levels are not directly يعني affecting it. يعني if they told you high or low, you might have chosen it. But they're telling you اسمع inside the exam don't يعني overcomplicate it. Once you read the word running, you'll think about exercise. Exercise, you'll think about muscles. Muscles contracting will squeeze the veins. على طول you should think about venous return. Blood calcium levels are not really mentioned. يعني in the calcium levels in the blood, not in the heart itself. They're here saying in the blood. Anyways, so I told you two factors. Stroke volume, you have a couple of factors that affect it. Venous pressure, how excited are the people to enter? Diastole duration, which is how often do I open the door and close it? And finally, exercise. Also preload, if I manage to stretch the ventricle, I will reach the optimal length and have a stronger stroke volume. And contraction, if I manage to kick people out by being good at pushing people, that's great. But what works against me is the arterial pressure. الباقي لنا الهارت ريت. Heart rate is affected by three things. ANS, the chemical, and the other factors that I personally don't care that much about. Autonomic nervous system, what could happen? In general, in life, you're at three states. You're either stressed during the exam, before the exam as well. You're either stressed, or you're right after stress, post-stress, or rarely, sometimes you are in a normal event, nothing is happening. All right? Stressful event, it starts with an S. And whatever starts with an S, the sympathetic system is activated. So what happens here? You see this whole line, you should know it all. They could ask from every part of it. Norepinephrine or epinephrine will be released. Which receptors will be activated? The beta-1 adrenergic receptors. What will happen? A decrease in the threshold, meaning it's more easily excited. Finally, and this is very important, I think they might ask about this. The sympathetic system affects which part of the heart? The SA node and the myocardium, not only the SA node. It affects both of them, SA node and the myocardium. Post-stress, خلاص, the exam is over, you need to go back to your normal situation. What will happen? Okay, now before this is important. Heart rate, once it's increased, a problem have arisen. What is it? Who could tell me what problem have arisen if we have a high heart rate? If you say it, you should say it out loud. High.
We're decreasing our EDB if we increase our heart rate.
صح. Why?
Decrease time for relaxation.
Exactly. In a high heart rate, we have a decreased time for relaxation. I'm closing my door very oftenly. I'm closing it every now and then. I'm closing the valves. There isn't time for blood to rush into the heart. So with a high heart rate, a problem arises, and that is that the diastolic duration is lower, so the stroke volume is lower. The sympathetic system is actually like عنده نية طيبة يعني. They're trying its best. Yeah, it's trying its best to compensate at least. What's the compensation? It increases the contraction. Remember, like 5 minutes ago, I told you to remember sympathetic system. It does increase the contraction as a way of compensation. Now, stress is over. Exam is finished. Now you want to restore your normal situation. Post-stress starts with a P, so what will be activated? Parasympathetic. It'll have acetylcholine. What will it do? It will increase the potassium channels, it will open them, and it will make it hyperpolarized. It's hard to excite them if they are hyperpolarized. So at the end, the heart rate will be down. Look at what I mentioned, only in the SA node. However, the sympathetic, both SA and myocardium are affected. Now, what about the normal event? We have sympathetic, parasympathetic. What will happen?
Parasympathetic is the dominant.
صح. In the normal event, we have a wrestling match, like arm wrestling, sympathetic versus parasympathetic, and actually the winner is the parasympathetic. What happens is, I remember my friend Yazan, he told you that the SA node has a 75 beats per minute like rate. But actually that's not fully true. The SA node is better than this. SA node could give you 100 beats per minute rate. But because of our wrestling match, because it's the parasympathetic one, it decreased it from 100 to 75. And this new state of SA node is what we call the vagal tone SA node. كله واضح؟ تمام؟ Nice. خلصنا autonomic nervous system. لا, wait, this part. I remember studying this part 1 year ago and keep forgetting it. Atrial brain bridge reflex, basically just know in the atrium, once it gets stretched, increases the heart rate. How? In 2 ways. First, the SA node is where is it located? Ventricles? In the atria. So when the atria is stretched, the SA node itself will be a bit stimulated. The second thing, the atrium has some stretch receptors. Once it feels it's getting stretched, it feels like, oh, we have to do something. So the sympathetic system is activated and the heart rate increases. Do you need to know all of this? I doubt it. Just remember, in the atrium, once it's stretched, heart rate increases. Okay? Now we're done autonomic nervous system. We have 2 more. Chemical and other factors, they're very quick. Chemical, we have 2 things. Either hormones, which are catecholamines, for example, and thyroxine. What about thyroxine? It could work on its own, but its job is like a player that assists other players. It gives passes. What does it do? It adds on the work of epinephrine and norepinephrine. All right? We have hormones done. What other chemicals? Ions. شنو نريد من الايونز؟ يكونون balanced. لا أكثر ولا أقل. يكونون balanced. That's the normal point. Nothing more, nothing less. But something that doesn't go well, sometimes we have a homeostatic imbalance that we need to study, which is, for example, hypocalcemia or hypercalcemia. How could you remember this? Remember calcium as the strength booster. Hypocalcemia, it's like the power of a car's engine. If there is too little power, in case of hypocalcemia, the machine won't work, the engine of the car won't work. You'll have a depressed or weakened heart. If you have too much power in the car's engine, in the case of hypercalcemia, it will be good to a certain point, you'll beat your friends, you'll be faster, but then it will reach arrhythmia. It will be too bad, you will have an irregular heart. So remember it as the power of a car's engine. That's for the calcium. What about the potassium? Hypokalemia, it's like a connection stabilizer. At first, the connection, if there is no potassium, the connection is weak. The heart also beats weakly, just like the hypocalcemia. It beats weakly and arrhythmically. However, if we have hyperkalemia, your connection is too great, it's amazing, the circuit will break. Khalas, it's done. Hyperkalemia, your circuit will break and you will get a cardiac arrest. Remember the word cardiac arrest. If you get cardiac arrest, you should look at the hyperkalemia. Hello? We're done. Autonomic, chemical, and one last part, other factors. They could ask, the age, once you're born, you have a high heart rate. When you die, you'll have a lower one. Throughout life, it will go down. That's one part. Males actually have a lower heart rate because they have a bigger heart. And for exercise, I already mentioned, heart rate will be increased because of the sympathetic nervous system. This you need to remember. Weirdly though, this is from my notes, that's why I wrote it like this. Weirdly though, fit people got low heart rate while resting. They have bradycardia. So if like a football player came into your clinic, inshallah after 10 years, and he was sitting there and you feel like they have bradycardia, it's okay. Calm down, he's alright. Because he's a football player, his heart is amazing. He doesn't need a high heart rate during resting. So remember this. All three parts are done. Happy life. We need to know what could go wrong with the heart rate. It either could go too fast or too slow. صح? For each one, you should remember three things. Heart rate, what is it? What is the number? يعني شلون نعرف the tachycardia or bradycardia? What are the causes? And if it stayed like this, what will happen to the patient? Tachycardia, let's talk about it if it's going too fast. If it's higher than 100 beats per minute, you can say this person is tachycardic. Causes: high temperature, stress, and drugs. During the exam, your heart rate is faster, right? Because you're stressed. During fever, next time you get fever, remember me and check your heart. It will increase your heart rate. All right? What will happen if someone has tachycardia for a long time? They will get fibrillation. Yazan talked about it. Fibrillation is like irregular beats. After a long time of working very fastly, the heart will get fibrillated. Bradycardia, a lazy heart. The heart rate would be less than 60. The cause would be low body temperature, and another cause is the parasympathetic system inhibiting it. It's like parasympathetic system doing a job. Well, we don't need a job, It's just pressing brakes at the wrong time. And if it stayed too long, the heart is not working well. So what will happen? The entire circulation in our body, it will be disrupted. So people will have a bad circulation. Not everyone, only unfit people. What about fit people? Their hearts will be hypertrophied. Their stroke volume is good enough that they don't need a high heart rate. Khalas, they're happy with their low heart rate and high stroke volume. Also, this is a side note, this could be a question and you get it right for those who are attending, and that is like bradycardia is a sign of cerebral edema after head trauma. So in the exam, if they said, oh, Ahmad Salim came into the clinic and suddenly he came after head trauma and they have cerebral edema, should look at bradycardia. What else? Let's see this question. In response, and the word in response is important, to an elevation in blood pressure, the cardiac control center would attempt to restore homeostasis primarily through which of these answers? He's too excited, yes, you. Yes. Parasympathetic, yes, parasympathetic, remember, post-stress. The word post starts with a P. Parasympathetic also starts with a P. Next question. Which of the following ionic conditions could lead to heart block and cardiac arrest? Remember, cardiac arrest.
Hyperkalemia.
hyperkalemia. صح. اصلا this question could be in the exam. and hypernatremia ما حد جاب سيرة الناتريميا. hyperchloremia ما حد جاب سيرتها. في're between A and C. And I told you hyperkalemia, remember it with cardiac arrest. All right. Now this. In comparison to a well-trained athlete, a non-athletic individual will usually have which of the following characteristics? I see less hands than usual. Oh, you, please. B. Who agrees? You agree? Well, you have an answer. B or C? You agree? Yaman?
It should be D.
Yes, exactly. Lower cardiac reserve. Remember when I told you what's cardiac reserve? Is the difference between your resting state and your active state. Someone who's not fit, they will not have a high cardiac reserve. If you're fit, you will have a larger one. We're done. We told you about stroke volume and heart rate. That's the difference between them. Stroke volume affected by venous pressure, how excited people are to come in. Diastolic duration, how often do I close the door and open it. Exercise, it pumps blood up to the heart. Another thing, preload, if it stretches and reaches its optimal length, it can push the heart, push the blood. Contraction, if I'm good at pushing people out, I'll be pushing them and having a higher stroke volume. What works against the stroke volume? High arterial pressure, or also called afterload. It's pressure on the opposite direction. Heart rate affected by ANS, chemically, and by other factors. Now we can't leave unless you know the homeostatic imbalance. Congestive heart failure. I remember last year, I used to hate this word, but at the same time love it. Yani, when I hear congestive heart failure, I'm afraid. Yani. But this is a simple definition. Congestive heart failure is when the heart is so bad at pumping that the blood piles up in the veins that fill it up. شوي weird, يعني تحسها puzzle, بس المهم, just know that the heart is bad at pumping and there is a blood piling up. Where? In the veins that is filling that side of the heart. Okay, what do I mean? Answer this question. The veins that supply the left ventricle, they come from where? From the lungs, صح. So if the left ventricle did not work, if we had left congestive heart failure, blood will pile up where? In the lungs. That's why they chose to call it pulmonary congestion. Pulmonary means lungs. Simple as that. Another question. The veins that supply the right ventricle come from where? Rest of the body. Legs mostly, but okay, rest of the body. So in that case, what will we call it? Peripheral congestion. And these are the two types of congestive heart failures. Either there is blood piling up in the lungs and those people actually suffocate like they're underwater, or you will have peripheral congestion, and you should know the sides. The two types, we should know the causes or the reasons behind them. And these are the two last slides, by the way. Reasons are 4. Coronary atherosclerosis, she told you about the supply of the heart. If we have fat between those vessels, the muscle won't be given enough blood, so it will lead to congestive heart failure. Another thing which is more severe, which is multiple heart infarctions. If cardiac muscles die, they are replaced by scar tissue, useless tissue, useless. It does not contract. So if we have tissue that does not contract, our muscle won't be strong enough to push blood out, so congestive heart failure. Number 3, persistent high pressure. If we have a lot of afterload, a lot of arterial pressure, our muscle won't be good enough at contracting. So what will it do? For example, if I'm on the heart, I'll go to the gym, get hypertrophied, and after a while, the blood that is supplying me is not enough. So I'll even die more. And it will lead to congestive heart failure. واضحة? Finally, dilated cardiomyopathy. People don't actually know the reason behind it. There are some speculations, but what you need to know, dilated cardiomyopathy is like the heart muscle is silly. It's too loose, it cannot even push. It is like wobbly. So it won't give the enough amount of contraction as much as we would like it to, leading to congestive heart failure. Lastly, as the last slide, I would like to tell you the treatment. Number one, okay, before number one. What are we having in congestive heart failure? What do you guys say? We have piling of blood, piling of fluids, either in the lungs or in the rest of the body. So what will we give them? Diuretics to remove the excess fluid. يعني في نسبة 40% 50% هاي الإجابة تجي في الامتحان. Diuretics to remove excess fluids. We have already congestion. There is fluid in a place that shouldn't be. So we need diuretics to remove this fluid. يحل المشكلة at least. Second thing, reducing afterload. People with hypertension, we reduce their arterial pressure in order to help out the ventricle. يعني the ventricle is suffering. It cannot push people out because the other way around, the pressure is high. So we help it out. Congestive heart failure, the contraction is low. So what will we do? Use digitalis to increase the contractility. This is the least we could do to the ventricles. We can help it out by increasing the contraction. And I think that's about it. Thank you. Yeah.